Hello, everybody. Welcome on behalf of Rayner to this session for the next hour, which over 700 of you have registered for from 66 different countries. Welcome to you all. Also, welcome to our three speakers, Mr. Allon Barsam, founding partner and director of Ophthalmic Consultants of London. Welcome.
Hello.
Professor Michael Amon, Head of Ophthalmology at the Hospital of St. John, Vienna. Welcome to you.
Hi, everybody. Hi.
And Mr. Andrew Morris, Senior Vitreoretinal Consultant at Royal Bournemouth NHS Trust. Welcome to you.
Thank you, Sam. Good morning, everyone.
I'm just going to share my screen here. Okay, so can everybody see this? Thumbs up? Great. All right. So I'm going to talk about my experience with trifocal technology, some tips and tricks as we go along in terms of when I feel that these technologies are beneficial and when possibly they should be avoided, and a few pointers on things that you can be aware of to manage problems with them if they arise. We'll talk a little bit about patient selection as well. These are my disclosures. So, the topic was how to restart or how to do, use trifocal technology or premium lens technology in the context of COVID-19. I don't want to be too preoccupied with COVID-19, but I just thought it'd be helpful to show changes we've made in our private clinic. In government, in the National Health Service in the UK, in government hospitals, there are a different set of challenges. But in the private sector, we have a little bit more control because we're not a hospital. We can control who comes in and comes out, pre-screen patients beforehand. But we have these floor stickers here to space patients as they come and register. And then at the registration desk, there's a disinfecting area with mask and hand gel, and patients are advised to wash their hands. And before they even enter the building, they're screened about questionnaires. And I think it's helpful also to show patients what the facility actually looks like, because they will be concerned about the ability of an individual clinical space to keep patients apart. We have an elevator, we have stairs, we have many rooms. We've apportioned some of the rooms as additional waiting spaces. We keep windows open. We're enjoying a lovely, beautiful summer in the UK at the moment. We have an air conditioning system in all of our clinic rooms and an air filtration system in our surgical rooms. Staff are wearing gloves when they're in contact with patients. Everything is sterilized and wiped down. And I just think that that's something that all healthcare practitioners across the world are doing at the moment, but also need to have this visual guide for patients so they know and are reassured. So this talk will be an introduction to trifocal technology. My personal experience is now well over 300 eyes of 150 patients implanted with the RayOne trifocal. I was the first implanter in the world to use the RayOne trifocal Toric, and have used it on well over 30 or 40 eyes since then. And I'll tell you my experience and publish some results as well. And then there'll be also some pointers on patient selection as well, and time for questions at the end. So this is just to remind you that all on this on Rayner's fully preloaded platform, there's a hydrophobic and a hydrophilic aspheric monofocal lens. They still make the spherical lens, although the indications for use are minimal. They're normally just the very high extremes of lens power required. And then there's the RayOne Toric, the trifocal, and the trifocal Toric. And this just shows the powers go from 6 diopters up to 30 diopters. This is the trifocal Toric in half diopter increments, and cylindrical correction in the IOL plane go up in 0.75 dioptric powers, which is similar to about 0.5 diopters in the spectacle plane of cylindrical correction. There's an online calculator where you just put the information in that you capture on biometry, and the calculator will automatically let you know which lens power is required. The technology of the lens material and shape is proven based on the monofocal platform, so reduced PCO rate, no glistenings. And there are 16 diffractive steps. There's a 4.5 millimeter diffractive zone, and it's designed to be pupil independent. The reduction, there's always light loss in any presbyopic correcting lens or any diffractive trifocal or extended depth of focus lens. And this lens was specifically designed to minimize the amount of light loss, so maximize the amount of light that is being transmitted to the fovea, and also to maximize the amount that is apportioned for distance. So they all split between distance, intermediate, and near. Michael will talk more about the Sulcoflex, but it's the same optics on the Sulcoflex. The main thing that trifocal technology has given us, which we did not have available with the older fashioned multifocal lenses, which were essentially also diffractive optics, but with only 2 focal lengths, is that it gives a increase ability for unaided vision in the intermediate range, which means that it acts in a more natural way. So patients don't just have 2 focal lengths happening, they have the 3 focal lengths happening simultaneously. And that can be shown in defocus curves. So patients have this preserved uncorrected intermediate vision, as well as what you'd expect, which is good uncorrected distance vision and good uncorrected near vision. That equates to reading at about 37 centimeters and intermediate vision at about 75 centimeters. This just shows you how the diffractive design works. And I think it's helpful to compare this with some of the existing trifocal designs, and then I think the benefits of this lens become apparent. So prior to using the Rayner trifocal, I was using the Zeiss trifocal. I then switched over to using the Physiol fine vision trifocal. And when the Rayner trifocal became available, I had no commitment to using it. I was just one of the people involved in the early studies, but on account of my results and the experience of my patients, I believed it was a better lens than the predecessors. One of the reasons for that is that there are less rings. So only 16 rings in the Rayner trifocal compared to 26 and 29 in the Physiol and the Zeiss, which I think accounts for why the light loss is less. But also, when you look at the profile of these lenses, and even if you look at the Allon profile, there's a lot of noise in between the diffractive gratings on the lens. Whereas in the Rayner lens, the way it's designed, it has these kind of sharp cutoffs, and I believe that's the reason that we have these patients. They have a significantly reduced complaint of glare in the Rayner trifocal compared to the other lenses. The other thing, and this has been shown in studies, some published and some unpublished, that I've been involved in, but whereas the distance, this is kind of quality of vision in various pupil sizes for distance and near, is quite similar in the Rayner lens compared to some of the other lenses. For intermediate, it is significantly better. And that is also shown in the uncorrected visual acuity with this lens. So it does give better intermediate vision, which is important for patients. And you'll also see the amount of energy distributed to distance is higher with the Rayner lens compared to the other competitor lenses. And distance vision or reduction in quality of distance vision is one of the things that people are most likely to complain of with these lenses. So I think the fact that Rayner have designed it in order to maximize the quality of vision for distance, as well as the intermediate vision, really shows an understanding of what patients want and need. And the PCO rate is very low. So here it's estimated at 2% at 24 months. Actually, when it first came out, I was expecting it to be a lot higher than this, because many of these lenses are very unforgiving of capsular opacification, but this is what I'm seeing in my practice, this kind of rate, about 1 in 50, no more. And that's also reassuring because it means you can do the surgery and discharge the patient. So these are our results. These were based on the first 36 eyes treated. And you can see that all patients were achieving 6/9 vision or logMAR 0.18. But I think the thing that's most impressive is that you have almost 80% of patients here achieving better than 6/6, better than 20/16, better than 6/5. And this is uncorrected binocular distance visual acuity. And the near visual acuity is also excellent. So the vast majority are reading N5, which is equivalent to about J2, which is as small as anyone would need for reading. Intermediate vision is always about 1 line worse because what you're viewing is further away, but we still see excellent uncorrected intermediate vision, and certainly better than the existing lenses that are available. We had patients, everyone complains of halos. That's to be expected with any trifocal lens, although none of the patients found this to be disabling within our first cohort of patients. I will tell you about one problem patient I had later and show you a video of how we handled it. And posterior capsular opacification rates were low. What we found is that the vision tended to improve between 1 week and 1 month afterwards. So patients sometimes were a little bit myopic in the early period, and once the capsular bag fibroses, then they tended to emetropize. And all patients complain of halos at night, but neuroadaptation was very fast. So although we tell patients they should expect 3 months to adapt and adjust to their new vision, many patients are happy after just 1 or 2 weeks. And we found this lens to be more forgiving than the predecessor lens to small amounts of refractive and cylindrical error. We had 1 patient requiring a laser enhancement. We had 2 patients with a large angle kappa. So the difference between the pupil center or the center of the capsular bag and the line of sight are not the same. So it's something some people worry about. And again, if I believe it's likely to be more than 500 microns, I may select not to use a trifocal lens. But actually, at the time I was using this lens initially, we were doing no selection for angle kappa and we didn't have any problems from it. We had 1 patient with zonulopathy where we used a capsular tension ring. And that patient is symptomatic of dysphotopsia at night because the centration of the lens is not optimal. And we plan to go back in and suture the capsular tension ring to recenter the lens. But that's in 300 eyes now treated. And a very high percentage of patients achieving better than 6/6 vision and N4 reading unaided. When I counsel patients before surgery, I tell them that there's a 97% chance that they will never need to wear glasses for anything ever again. The 3% is for small print reading in low light levels. They may want a pair of +1. Some patients insist on holding things at 20 centimeters or 25 centimeters. And then if their distance vision requires enhancement, we do laser enhancement for them, but it's not required very often. So this is a patient, an unusual case. The patient suffered from a totally routine surgery. Cataract patient had capsular phimosis and the lens decentered. So you can see the 3 Purkinje reflexes here, which is the line of sight, and the center of the lens is here. This video just shows how we manage it. And the patient was symptomatic of dysphotopsia, reduced best corrected and uncorrected visual acuity. So the fibrosis is, and the patient was also consented for a lens exchange. If we hadn't been able to center it well, we would have exchanged this lens for a monofocal lens. But actually, this was about 3 to 4 months after surgery. We were able to free up the adhesions between the anterior capsule and the lens, but actually the lens remains decentered. So, and it's due to the capsular phimosis. So we're making a relieving incision here, hoping that it will center better. And then just slightly enlarging. And then here you can see that immediately the capsule is torn out to the equator. So no more manipulation of the anterior capsular rectus is possible. But because the lens is free and the capsular phimosis has been broken with the scissors, it is now possible to dial the lens and free up the adhesions just gently and carefully. And then by doing this, without the capsular phimosis, you can now see that the center of the lens is well centered on the Purkinje reflex. And again, I think I just dial it around so that I know these haptics are away from this, the area where I've relieved the capsular phimosis. It's kind of a little bit heart-wrenching to watch this video because the experienced surgeons will be aware of all of the things that could possibly go wrong, but the patient was counseled that the lens might need to be removed. And so we were ready for more surgery should it have been required. And here I'm just freeing up a little adhesion between, the haptics meant to compress towards the optic, but I'm just freeing up by manually there a little bit of adhesion there. But with a bit of manipulation there, the lens now centers perfectly and the patient's symptoms were gone on the first post-operative day. So, you know, we always worry that once we do the surgery, it's permanent and nothing else can be done. But actually, in very rare cases where there are positioning issues or where it needs to be revisited, there are options to sort the problem out for the patient. And this is a video now of a routine implantation. This was my first implantation of the RayOne trifocal Toric. So I was using, let's see if this will play. It's femtosecond cataract surgery. So the capsular rectus has already been made with a laser. And also the lens has been, let me see if I can, 1 second. The lens has been fragmented as well. I feel like my computer's telling me to fast forward, so I'm just going to forward it through. But essentially, we're just injecting the lens here, It's because it's a one-handed injector. It means that you have your non-dominant hand available to counterfixate the eye, which is very helpful with topical anesthesia. We've already pre-placed the marks for toric alignment. The marks are very easily visible on the posterior lens surface of the IOL, and then we just dial it around. And this was the world's first implantation done here. We're just videoing it, and the results have been fantastic. And although I say that the trifocal non-toric version is very forgiving of astigmatism, clearly if you have the option to fully correct astigmatism, the results are better. And so I've been increasingly using the trifocal toric version since it's become available. The results have been so good. I was involved in a study with 4 other surgeons where we were looking at the initial results. We looked at the pre and post-operative level of vision. We looked at things like toric alignment and centration afterwards, which, as you can see here, are excellent. We saw all eyes were within half a diopter of emmetropia, and all eyes were within 0.75 diopters of cylindrical correction, with 71% of eyes within half a diopter of cylindrical correction. So very effective at treating cylinder. And you can see here in the red is the preoperative refractive cylindrical error, and in the blue is the post-operative refractive cylindrical error. So all patients are being pushed into this kind of comfort zone of under 0.75 diopters, with most of them under 0.5 diopters. The mean uncorrected distance, intermediate and near visions were all excellent, with logMAR between 0 and 0.1. So, sorry, this looks a bit jumbled, this slide, but I'll just read it out for you. So for patient sophistication, what it says at the top here is, despite the increasing sophistication of our patients, they may not fully understand what is important with regard to selection, vision correction procedures. And what I mean by that is that you'll sometimes have patients coming to you saying, I would like to have this kind of lens or that kind of lens. Sometimes they even tell you the make of lens they want. And in a nice way, in a non-paternalistic way, I think it's important for us just to remind them that just because their friend had a certain lens doesn't mean that that's the lens that they should have. And that every patient's eyes and their own vision requirements are not the same. And the surgeon needs to understand and follow selection criteria to avoid unanticipated and unwanted results. And patient motivation is really, really critical. Everyone, you know, I'm sure there are going to be many questions at the end of this talk and at the end of during the discussion where people will give me scenarios of would you use a trifocal in this situation or that situation? And every single question will need to be prefixed with how motivated the patient is to be independent of glasses. And I think that for those who are yet to enter into the presbyopic correcting world, either through lenses or otherwise, once you start speaking to patients about this, you realize how much some patients hate wearing glasses. We as doctors may not have that problem. I can see Michael wearing glasses there as one of the audience. But that doesn't mean that what we like for ourselves is necessarily what the patients will or won't like for themselves. And I would encourage all of you to read this article published in Cataract and Refractive Surgery Today by Stephen Dell, who was the medical editor at the time, which is entitled All Hail the Near King. And what it very cleverly does is it reminds us of all the things that have changed in the modern world to make near vision so important and uncorrected near vision so important. There are cars driving themselves through the screen now. We always used to talk about fighter pilot vision, but what matters now is being able to operate a drone again through a screen. And the distance being the dominant and most important thing to patients is not actually what you'll find out when you speak to patients and ask them about their life and what they want and need. And it's worth reading that article. And so the ability to use lens technology to allow people to have uncorrected near vision is more important in 2020 than it ever has been in the past. It's important to review the patient's visual needs and the expectations. Do not assume a one-size-fits-all approach. You need to find out their vocation and avocation. So what do they do for a job? What are their hobbies? I've even started asking patients about weird hobbies that you would never even expect people to have, because I've had patients where you come in and you ask them about night driving, so they don't do much night driving, but they don't tell you that their hobby is stargazing. And so we do actually always ask patients about, do they do anything in low light levels? We actually specifically ask them about stargazing now because we don't want to be caught out again. But it's worth taking the time before surgery to find out exactly what your patients do and what they need. And then the presbyopia status at the time of surgery is important. Sometimes we're put off by younger patients because we think that they're more, that they're going to be more fussy about the outcome of surgery, and that the older patients might be a bit more forgiving of quality of vision issues. And actually, It's actually the opposite, because younger patients are not presbyopic, and if you have to remove the natural lens of their eye because they have a cataract, then I would argue that a trifocal lens is more appropriate in them, because you need to try and restore some uncorrected near and intermediate vision. So again, just to bear that in mind. People sometimes ask about monovision, and I do use monovision occasionally. It has advantages. It's cheap. It's reversible in terms of the fact that you can laser correct the non-dominant eye if they don't like it. They don't get glare and halos. But the problem with monovision is that they get reduced stereopsis. So these patients are not seeing depth in the same way that they would be if they had both eyes treated in a similar way. The enhancement rate is very high because the dominant eye must achieve emmetropia. And if it doesn't, then you have to do a laser enhancement or a lens-based enhancement. There's more chance of anisometropia, so they will complain of an imbalance between the two eyes. They complain of blurred vision at night because of night myopia. And also patient acceptance is low. They generally don't like the idea of having two eyes working in different ways. And so for that reason, I tend to only use monovision if I feel that there's a reason to not use trifocal lenses on a patient that's motivated to be independent of glasses. I do, however, like it in patients that are already enjoying the setup with contact lenses. So they already have kind of experienced it. And then if there's a reason you don't want to that you shouldn't or don't want to use multifocal lens technology, if there's maybe an epiretinal membrane, or they have high astigmatism or some degree of irregular astigmatism. But with monovision, you have to be very careful of suppression, things like mild amblyopia or microtropias. So we have our optometrists check patients for any suppression there. Who do we avoid for trifocal lenses? Well, we want the astigmatism to be regular. So that means that we do a topography and we want to see a bow tie. And if you don't see a bow tie, then it's likely to be irregular. We may have reservations then about using trifocal technology. If patients have a very poor ocular surface that we do not think is going to be treatable, potentially rheumatoid arthritis and diseases such as that, we again wouldn't use presbyopic correcting lenses. And then patients that don't really engage in the consent process and are not willing to, we don't think we'll have a proper level of understanding about what's involved. What I say to every single patient is that there is no technological solution that will give them the vision that they had when they were 20, when they had their distance vision corrected in glasses or contact lenses. I think it's really essential that they understand that, because they have to accept some quality of vision issues in order to achieve spectacle independence, for example, halos at night. And if they don't accept that, then they have to accept glasses. They can't have everything. So they have to decide where they want the compromise to be in their life. And providing that's explained to them carefully, the uptake I find to be totally reasonable. I'm using trifocal lenses in about a quarter of my patients. I'm certainly not using them in 95% of patients. I know there are some out there that do, and I think that's possibly overusing them. I think in my practice, there's an argument I should be using them more. So I think it's in the years ahead, I'll look to increase my use, but certainly the ones that have them are on the whole very satisfied. If you want, we ask patients directly about these things, but there are questionnaires available online. This is again by Steve Dell. This is his pre-screening questionnaire where he asks patients about their lifestyle and what they need and what they want. You have this information before they even come in to see you in the clinic. There are simulators available online which show you what it's like. This is a slightly kind simulation of trifocal toric vision, and this is a very unkind simulation of night vision problems. And I think the reality for most patients is probably somewhere in between the two. But again, for patients that don't want to wear glasses, they're happy, and we explain beforehand the neuroadaptation period that's required, and the chair time beforehand to speak to patients is really essential. Do not rush them into the decision-making process. So in conclusion, I've talked to you about some of the technology, my own personal experience, some of the early results, some patient selection considerations. And I think in terms of questions, I'm going to leave questions to me until the end so that I can give the other speakers time to talk. So we will note all the questions. We will field as many as we can at the end, but I'm going to stop sharing my screen now and ask Michael if he will share his screen. And so I'm going to introduce Michael Amon from Austria to talk about Sulcoflex lenses. Thank you, Michael.
I hope everybody is hearing me. I would like to give you a short overview on our situation with COVID-19. We had a very early lockdown in Austria. We started at the 16th of March to lock down, and at that time we only did emergency surgeries. Since almost 1 month now, we started again to do our elective surgeries. We have one of the world's lowest infection rates here in Austria. but all patients who are scheduled for surgical procedures are tested for COVID-19 2 days in advance. And if they are negative, we do the surgery. So we have no problem with aerosol or something else during cataract surgery. And we use FFP2 masks during surgery in order to avoid any contamination. Now we have a volume of about 80% to the pre-COVID time. So we are almost close to the reality back again. I want to talk about the Sulcoflex Trifocal lens, which was launched 2 years ago now in 2018. I will talk about the material, the surgery. I will show you 2 surgical videos. I give you the results, and finally we will have some conclusion. Material and design, the history of this lens. As an add-on lens is put into the sulcus, it's very important that the lens is made of a biocompatible material, especially of UL biocompatible. So we choose a hydrophilic material which has shown to be very biocompatible as compared to hydrophobic materials. And we did studies years ago in the early of the century, at the end of the century and in the beginning of the 20th, where we could show that UL biocompatibility is advantageous in hydrophilic materials. So this is one important thing. Right now there exists 3 add-on lenses on the market: the crystal lens, the Rayner Sulcoflex lens, and the FRCOphth lens. All 3 are hydrophilic. In 27, I put the world's first lens into an eye. It was an aspheric monofocal Sulcoflex lens. And since that time, we have implanted worldwide over 40,000 lenses. So there's quite a big knowledge about that lens. In 2008, the first Toric lens was implanted and the first multifocal and multifocal Toric version. There also were some cadaverized studies, and they showed that this lens has a good centration and appropriate sulcus fixation and minimal interaction with uveal tissue, which is important because we don't want to have a contact of the lens surface to the iris and to the lens which is put into the bag. So there should not be a contact zone in the center of both lenses. There are also some, and that's very important, I think, optical bench studies. As there are more interfaces and surfaces within the eye, it is important to test if there are more reflections. It was not found. Or if the optical quality is worsened by the 2 interfaces. Or if there's an additional light loss. And this nicely has been shown, and it is going to be published in the Orange Journal soon by Coramnia, that it is not the case. There's only less than 1% light loss, and there are no, and the optical quality is very similar to a single in-the-bag lens. That's a very important fact, I think. So we don't have to be concerned about putting a second lens into the eye by optical arguments. We did over 200 years in a follow-up of now 13 years, and we could show that at this first series, we had no iris trauma. There was no pigment dispersion, no pigment dispersion syndrome. Some tiny pigment spots sometimes were found, but there was no glaucoma or some pigment atrophy. There was no interlenticular opacification at the as we know, the second lens is put into the sulcus. There was also, in all cases, a positive iris distance, which is important. And there was also a positive optic-to-optic distance between the 2 optics to avoid a contact of the lens in the central lenses in the central zone, inducing a hyperopic defocus. These are the main outcomes in our early study, in the first study. We also performed a centration study, and that's quite interesting. We could show that the centration of the sulcus lens within the same eye was advantageous to the centration of the bag lens. And even more, it was stable. As in the sulcus, the lens has a fit and is not changed by any compression forces caused by the capsular bag, which is the case in a capsular bag lens. So the centration was very nice in the Sulcoflex group. We found some specific indications, for instance, in children where we have a myopic shift, where the eye is growing. We could implant these lenses and try to always adapt the refraction to the refractive situation of the patient. So in some cases, we removed the Sulcoflex lens and exchanged it to another one, which had the exact refraction for the situation of the age of the patient in time. So here you see in the first video, you saw the implantation 5 years ago, and in the bottom, you could see the same eye 2 years later after an exchange of these two lenses. So there are several indications for several specific indications for add-on lenses, in my opinion. Silicone oil is another one. You create a refraction difference when you put in silicone into the eye, and also some corneal alterations may be a good indication for add-on lenses to correct the refraction, the ametropia. So the conclusion after 12 years is that supplementary IOLs are effective for secondary enhancement of the surgical result and for primary Duet implantation. Duet implantation means we do a cataract surgery, implant a monofocal in the bag lens, and in the same procedure, we put a refractive at that time. Now we have a diffractive trifocal lens on top in order to have a multifocal lens system within the eye. And all these situations represent a reversible or exchangeable technology for the future, which is, in my opinion, a big advantage. Which was the next step? The next step was to create a trifocal diffractive lens on that same platform. So as we heard by Allon already, there is a very good and nice optical technology with a trifocal lens by Rayner, and the same technology with the 16 rings and so on, you heard that already, was applied on the platform of the add-on lens. So we have now an optical system where we can combine a monofocal lens and put a trifocal multifocal lens on top as a secondary enhancement for patients who are already pseudophakic, or as in a Duet procedure in order to create multifocality in our cataracts or clear lens extraction patients. When we compared the trifocal lens, the RayOne trifocal lens, to the similar competitors on the market, we found very similar results. So we could show that, and we heard that by Allon very elegantly, that the trifocal system works as very nicely in comparison to the competitors. About this surgery now, what is in a case of ametropia, how do we calculate the lens in order to create ametropia? That's quite easy and straightforward. We don't need any measures, we don't need biometry. If the ametropia is within plus and minus 7 diopters, we just need to multiply the spherical ametropia by 1.5 if the patient is hyperopic, and by 1.2 if the patient is myopic. That's quite easy and straightforward. In my Duet procedures, I use my standard calculation formula for the bag lens. I go for the closest minus, so I go almost to 0. And then I put on a Sulcoflex trifocal lens with no distance correction, and the add of the intermediate and near distance. Here you can see my first case. It was the world's first implantation Duet procedure of a multifocal trifocal lens, cataract extraction in the bag implantation of a Rayner hydrophilic lens at that time. Then it is important that you aspirate the viscoelastic from the bag, that you have cleaned the bag from viscoelasticum. Now you prepare the sulcus, you lift the iris a little in order to implant the add-on lens nicely behind the iris. Here you see the lens. It's a very soft lens. It's very thin, as there is no diopter, almost no diopter to be corrected. And here this is the injector. It's important that you put the lens behind the two hinges and that you put it quite anterior to the nozzle, and then this is a single hand use injector by Medicel. It goes through 2.2 millimeters. This is a 2.4 millimeter incision at that time, and here I implant the lens. The leading haptic opens very slowly and controlled, and the trailing haptic does the same. You see the haptic itself is very soft, and for that reason it is important that you take time and remove the viscoelasticum after implantation so that the haptics may open and position in the sulcus by themselves. One important thing is that you remove the viscoelasticum from the interface and from the anterior chamber. So here you will see that I lift the lens first, go behind the Sulcoflex lens, remove the viscoelastic from there, and then a second step, I remove the rest of the viscoelastic. This is the end. You see a very nice centration of this Sulcoflex lens. There is also an indication for secondary implantation. I will not show you the whole video now, but here you see after cataract implantation of a Sulcoflex lens, and in that case, I did the YAG capsulotomy after implantation. Even though if you have an open capsule, you also may implant the lens in a secondary fashion. But in that case, I decided first to implant the lens and do the YAG capsulotomy later on. But one important thing for me is the reversibility, explantability. And so I show you here the explantation of a lens. Fortunately, it was very rare that I explanted that lens, but here you see a multifocal Sulcoflex lens. I just take the lens at the optic and pull it out through 2.4 millimeters without any stress. So I think it is really easy and it is reversible. And it's an option you have even in cases where you have a long distance between implantation and explantations. I had that experience with children where I exchanged it after 2 or 3 years. So it is not fixed, it is not ingrown. You can explant that lens easily through a 2.4 millimeter incision. So the results of the Duet implantations, I will go through that very quickly. We did the first study with 40 eyes. It was a bilateral surgery at that time, and we found a very nice result. It was absolutely similar to the RayOne trifocal lenses. So here you see the defocus curve, very nice intermediate and near vision results. So the optical quality of the Sulcoflex Trifocal is not significantly different to that of the RayOne Trifocal. The only one thing is it is reversible. The secondary enhancement, there are some cases which are ideal. There was a case with some heterochromia and a well-centered lens which was implanted already in the eye, but it was hyperopic. So I decided to put a multifocal lens on top of that right eye, correcting the ametropia and correcting the presbyopia. And on the left eye, I did a Duet procedure in order to make the patient spectacle independent. And here you see the results. The patient had a more than 6.6 vision result without any glasses. It was a very nice result. So I think secondary enhancement of the patients is also a feasible tool, and it is a good indication, but it is important to tell the patient that after the implantation for pseudophakic patients that he will have to deal with some halo situation, because that is in all these cases to be expected, and it's not to expect in monofocal patients. So in conclusion, we had excellent visual acuity results across all the distances. The results are comparable to trifocal in the back lens at least, but, and that's the important thing, supplementary IOLs offer an adaptive option. They are reversible, and as Allon mentioned, you have to consider if you use a multifocal lens or not. With that system, I think you definitely have to do that, but you create a wider field of indications, because if the patient doesn't like it because of lack of neuroadaptation, or if after years the patient develops glaucoma, CME, diabetic retinopathy, you may explant that lens at any time, and increase his contrast. So you have the option of fine-tuning. These lenses are in quarter steps between minus and plus 1 diopter, and you have the option to exchange it in the future, as I mentioned. So in conclusion, the main indications today are in phakic patients, multifocal Duet implantations, and in pseudophakic patients, the multifocal enhancement, as I already mentioned, and the biometrical surprise. Thank you very much.
Thank you very much for that, Michael. There are a few questions that I think I'll just put through to you. One of them is asked which viscoelastic you use for the Duet implantation.
I use my standard viscoelastic. It is a Allon.
Okay. And then if you have a patient who has had a monofocal lens in one eye and they're seeing you for second eye cataract surgery, and you want them to have a multifocal or trifocal lens, how do you approach such a patient? Obviously, they're all a little bit different, but do you have can you answer as to what you would do? Would you do in the bag in one and a Sulcoflex in the other? Would you do Sulcoflex in both, or do
I routinely do for multifocal lenses. I always do Duet procedures. So I never use a trifocal lens in the bag, because I want the reversibility. So in that case, I will do the cataract in a Duet procedure and maybe bilateral. Right now with COVID, I would do it bilateral, but otherwise maybe 1 week later, I will do a secondary enhancement of the pseudophakic eye. I routinely do Duet. I don't like multifocal lenses in the bag because it's, in case of explantation, it's more difficult.
Okay. And that's answered one of the other questions, which is whether you prefer in the bag or the Duet procedure. Fine. I think that those are the main questions on the... okay, so someone's asked, do you think the results with a Duet are exactly the same as with an in-the-bag trifocal?
Our results show that, but these are clinical results. I think it is not 100% clear with clinical results to give that information. But the main thing for me is, this was a aha experience, is the paper of Coramnia, who did it in vitro. So in an optical bench, he was measuring different multifocal lenses, comparing it to the Duet situation. And he didn't find a lack of optical clarity, and the strail ratio was the same. So there exist some lenses which have a worse strail ratio than the Duet procedure. I think it's absolutely the same. And for that reason, I choose that Duet procedure as surgery of choice for my patients in that case.
Okay. I mean, I suppose the question wasn't posed directly to you, but I'll just let people know what I do, just because people always feel slightly differently about these things. I have used the lens in the Duet procedure, and I've also used it as a secondary enhancement. And in all cases, the patients have been very happy. So I've had no problems doing it in those ways. I just personally prefer to do in the bag if I feel confident that the patient has been appropriately selected. So in my opinion, if there's patients where you may have reservations about using a trifocal lens, then I believe that it gives you additional reassurance. But I don't worry so much about what happens if they develop macular degeneration or glaucoma in the future, because that happens to many patients and they don't tend to come back to clinic because either the lens provides some kind of magnification, or any kind of quality of vision issues are very mild. And in worst case scenario, the lens can be explanted at a later date. But I understand the benefits potentially of doing it always as a Duet procedure, but just in case people are wondering, it's not what I do in my practice. I think we'll have more time for discussion at the end. So I'm going to ask now if Andrew Morris from Bournemouth, the beautiful south coast of England, will talk a little bit now about the RayPRO and about telemedicine, a little bit more about COVID-19 as well in his experience. Thank you, Andrew. If you could just share your screen.
Hello, Allon. Can you hear me all right?
Perfect.
Great. And nice to see you again, Michael, as well. Well, thank you very much, Allon. I'm going to run through my experience with RayPRO, which is a device or of receiving and collecting patient-related outcomes, previously known as PROMs, you might have heard of. Firstly, yes, that's the South Coast today. Well, not today, but very recently. And I'd like to thank the Rayner team, Tim, particularly in behind the scenes, helping make this webinar work, Sam Carter, James, and Carrie. And how did I hear about RayPRO? Well, this gentleman dropped in to my practice or to my hospital. His name's Austin, and his enthusiasm for the Rayner lens and the RayPRO method was very catching. So what goes on with RayPRO? It's a simple method, which is part of the beauty, because it doesn't take up too much time as a surgeon in addition to talking to the patient and gaining consent. It can be blended in with that. And I'll just run through a few slides to show how I've used it for the patients that I've treated for with the RayOne monofocal, so diverging a little bit from the trifocal. So when you see the patient's registered on the RayPRO server. They are then emailed over a period of 3 years. So this is about getting feedback to the surgeon specific to that patient and that lens and that hospital. The surgeon can easily access that, that data and most easily on a mobile phone. And Rayner also process and aggregate that information. So patient registration, and this is thanks to Rayner for the slide. The patient details are entered in a very routine manner, and a confirmation that they have given their consent. So I get written consent from the patient that they will don't mind receiving emails from Rayner. You place your own clinic here. So we've got Allon's clinic up here, and the surgery date and the operated eye, the actual lens you're using, and again, confirmation that the patient's registered and given their consent. So these are the pros, and this is what you might get back. And this will be displayed in almost real time on your phone. Once you've gained, I think, 10 patients initially, and as you accumulate patients on your RayPRO registration, you will get the information back at this interval. So 2 weeks, 1 week, sorry, 3 months, and we're approaching the target vision outcome, and then at 1 year, whether the patients needed any additional procedures. Useful if you are starting out with any new lens to you to see whether they've been acceptable in that first year. 2 years, again, any additional procedures, including YAG laser, and then finally at 3 years. So the next slide is showing my short experience of using RayPRO, which is 3 months so far. And this is the kind of information you'll get displayed on the RayPRO app on your mobile phone. So this is showing surgeon satisfaction. The other questionnaires are aimed at hospital satisfaction, whether anything else has been needed post-operatively, and spectacle independence. So this is us back operating in Bournemouth post-COVID, or during COVID actually, for all the emergency procedures. And this one on the right-hand side shows the overall satisfaction with the outcomes. So the patient is sent an email 1 week, 3 months, and then 1 year, 2 years, and 3 years. This slide shows the surgeon satisfaction again, but this time displayed as over a period of time. So you can see when you started using that particular lens or that particular hospital, and it shows how that progresses over the period of time that you're getting your data returned to you. You can see quite a sharp drop-off when the COVID crisis hit. But this is the surgeon satisfaction hospital expecting one day, Allon, maybe to compare my results with you. And the spectacle independence at distance, this is just the RayOne monofocal. And sure enough, the satisfaction with spectacle independence dropped off for intermediate and near. And again, this is at 3 months. And this is the final slide, just showing us back at work and the wonderful theatre team. And also like to say thanks to Ray McCrudden, who's our gastroenterologist in the hospital, who has a sideline in excellent and unusual photography and came along to give us this image. And once again, thanks Allon and Michael and the Rayner team, and look forward to any questions you have.
Thanks very much for that, Andy. I have a question for you, Andy, which is the actual practicality of getting patients to put the information into the RayPRO. How did you actually achieve that? Did you have the nurses do it, or were any juniors in the hospital involved in it? Was it while they were waiting to see you? How did it actually work? Obviously all prior to COVID, but how did it work?
It was a simple consent sheet, which just said, you know, that the patient agreeing to have their email released to Rayner. My secretary produced that kindly. And then I would just bring it up actually at the consultation, ideally, just saying, you know, they will often ask, you know, when will I be followed up or when will I be seen? And I'll say, well, initially it'll be 2 to 4 weeks, but in the long run, we'll also be gathering information, if it's okay with you, regarding how happy you are with the lens and your vision going forward. So I bring it up then, and if I don't get the consent at that point, I ask them again on the day of surgery. And then for entering the data, I usually do that in theatre, in between cases, for those that have given their consent on the mobile app.
Okay, and then, but then you also, you're collecting data afterwards as well, aren't you?
Yes, only at the well, at the post-op visit, any complications and anything else that's needed to be done is entered then. Otherwise, it's all patient feedback. This is purely patient-reported outcomes.
So they get emailed separately. Basically, you consent them, you collect their email, and then they get a email asking for the information, and they put it on it's then available for you.
That's right.
Great. Okay. Fantastic. Michael, I will have a question for you, but there's one question that's got 12 thumbs up that I'm going to just answer before people, you know, just to make sure no one leaves before we've answered this one, which is, the question is, how do halos with the Rayner trifocals compare with the Zeiss Physiol in your experience, i.e. frequency and severity? And I would say the following, that when I was, first of all, the Physiol and the Zeiss are very good lenses, and I didn't have any kind of major problem with them. But what I found switching over to the Rayner lenses was that glare they essentially stopped complaining of glare. So glare becomes incredibly rare as a complaint with the Rayner trifocal. Halos are present with all of these lens options, but the halos are crisper and more pronounced with the Rayner trifocal. So in my experience, you're discarding glare in order to have a clearer, more pronounced halo. And I find that that's much more acceptable and tolerable to patients, because they can appreciate the halo as an optical illusion when they're night driving, and their brain quickly learns to ignore it and filter it out. So they have this neuroadaptation capability, whereas glare scatters light in a way that can be confusing and incomprehensible to them. So although we would obviously love to have a lens that doesn't give any quality of vision issue or any aberrations whatsoever in low light levels, that doesn't exist, at least not one that makes you also independent of glasses. And so I find that halos are more acceptable than glare. So they have crisper, distinct halos and less of them, because there are 15 rings rather than 26 to 29, but no glare. So hopefully that answers that question. Now, Michael, there were a couple of questions for you. I'm getting some questions on things like, does it matter which lens you put in the bag and which one you put in the sulcus? So presumably what they're thinking is, you know, because obviously you could use a Toric Sulcoflex, for example, or you could use a monofocal Sulcoflex and have the trifocal in the bag. Are there any circumstances where you wouldn't have the trifocal in the sulcus?
No, I don't think there is a problem with any material or any lens. I have implanted Sulcoflex lenses on silicone material, on hydrophilic, on hydrophobic acrylic material, on 3-piece or 2-piece lenses. I think it doesn't matter. As there is no direct contact between the two lenses, as there is a concave posterior surface of the Sulcoflex lens, it shouldn't matter. The only one thing, it is important that there is no zonular problem or something like that. If you have a luxated or subluxated lens, definitely it is not an indication. Or if the first lens is in the sulcus, I think it might not be advisable to put that lens in. But as the first lens is in the bag, I think the material and the design doesn't matter.
Okay, thank you. I've been asked this question. If there is PCO, if there is capsular opacification in trifocal, does it have any effect on halo and glare? And the answer is yes, it does. So if I have a patient that is complaining of halo and glare and they have posterior capsular opacification, then I will always do a YAG. And I think that you need to have a lower threshold for doing a YAG in presbyopic correcting lenses, because anything that interferes with the passage of light to the fovea can potentially become further degraded by the way that the lens handles light. And the same is true of the ocular surface. You need to aggressively treat any ocular surface disease prior to surgery and afterwards to optimize it in order to ensure that patients can have the best vision. Michael, a question for you that I will also answer, but there's a question about, do you use these technologies in emmetropic patients?
I use if it is a cataract, yes. If it's a clear lens extraction, depending on the age and on the need of the patient, the wish of the patient, but not routinely for clear lens in emmetropics. Yeah.
So I will say the same, but I have used the Rayner trifocal in refractive lens exchange in emmetropes with good results. My threshold for doing it is clearly higher because you're dealing with patients who have, in theory, perfect distance vision uncorrected. But I have used it in some of those patients who are very debilitated by the need for glasses and contact lenses, and they've been very happy. Often these patients don't have other eye pathology, so actually, although their measure of what they can potentially gain from it is different to someone who has a cataract or who has ametropia, the eye itself is often tuned to perform well with these lenses because they have healthy ocular surface, healthy macula, et cetera, et cetera. Right. Andrew, I'm going to ask you, because I know that you're not a kind of big presbyopic lens user, but are kind of interested in potentially using more presbyopic lenses in your practice. Do you have any questions for myself or Michael about anything that you've heard today or that is on your mind?
Thanks, Allon. Well, no, that's right. I have tended to be a monofocal person so far, and always brought up the concern when patients ask, that there are side effects with the multifocal type lenses. But I think it's fascinating hearing you and Michael talking about it. The one multifocal I've ever used was the Duet, actually, because we were both, me and the patient, unsure about whether it was the best thing for them, and that worked well. That was a Sulcoflex, at the time, multifocal implant. So I think you've answered it, Allon. I mean, you've demonstrated that you can get very good results implanting it in the bag, and I think if I venture more into the presbyopic cataract practice, then I would be probably following Michael's footsteps of aiming for the Duet procedure, hearing that there isn't too much of a downside with the double lens, and with the easy explantation if they don't get on with it. So no, thank you.
Thank you, Michael. Is there an optimum position for haptics of the Sulcoflex when you're doing the Duet procedure? In your experience?
In the beginning, I thought it is not, but right now I orientate the haptics 90 degrees to the haptics of the first lens. So I try not to be on top of the haptic of the bag lens. I put it 90 degrees. So in secondary, it depends on the position of the first lens, definitely. Or if I do a Duet procedure, I usually do the bag lens on the 12 o'clock haptic position, and 90 degrees to that I do the Sulcoflex lens.
And are there any considerations in eyes that have unusual anatomy, such as short eyes or long eyes?
Not the length. I think I put that lens into children with 14 millimeter of length. So I think there's space enough in the posterior chamber for 2 lenses, definitely. Yes. I wouldn't implant that lens in severe PEX situations or something like that, or very high myopic patients where there is a phacodonesis already because of the danger of loss of zonules after implantation and secondary subluxation of the Sulcoflex lens. But otherwise, from the length or the wide to wide distance or something, anterior chamber depth, I have no concern. I have no concern. No.
Someone's asked about peripheral iridotomy with Sulcoflex implantation.
I don't do it routinely. I do it in children and very short eyes below 20 millimeters of axial length.
Okay.
Not routinely.
And Andy, someone's asked about the RayPRO system. In terms of how user-friendly is it and how time-consuming is it? So can you give an idea of that?
Yeah, thanks, Allon. I was just typing a reply to that and managed to delete it before it sent. Easy to use. It's very, very intuitive, and I think to start with, I was doing it online, and then they pointed me towards the Rayner team pointed me towards the app, which makes it easier as well. So very simple to fill in, and in between patients while you're doing the paperwork, it's quick. And again, once you get used to fitting in the consent, it all works. And then, yeah, very, very useful to see the post-op data coming through in real time. Encouraging to see that the patient's doing well, even when you haven't heard from them, and before you next see them.
Okay.
Straightforward.
Fine. I mean, there's a question I've been given it. Well, the question could go to myself or Michael, but it's about the centration of the trifocal. So, how forgiving is it, and how centered does it need to be? And the first thing I'd say is I don't routinely worry too much about how centered it looks while I'm operating, because I think in the bag there's going to be some capsular fibrosis and it may move a little bit. But you do have some idea prior to surgery of how you think this lens will center via angle kappa or angle lambda. But basically, depending on which machines you're using in terms of biometer or topography machines, most of these machines will give you an XY coordinate of the difference between the pupil center and what it thinks is the visual axis or the line of sight. And there's an assumption that the pupil center is roughly where the lens will sit, although that's not always the case. The thing is, there's a lot of variables and a lot of things that you don't necessarily know. And so I used to totally ignore it. There have been a few studies that have been published in the last year or two that say that if it's more than 600 microns on the X or Y axis of discrepancy, so the length of travel between those two measurements, then patients may be less likely to be happy. So if you see a really huge angle kappa or angle lambda, then you might want to think before using an in the bag option. But according to Michael, the Sulcoflex option will center well anyway, and it does center differently in the sulcus to how it would center in the bag. So in those cases, probably the best option is to do the Duet procedure.
Yeah, I agree. The good thing is that the Sulcoflex lens stays and is not going to be decentered after surgery. As with the capsular bag, you might have some movement afterwards, as there is a capsular contraction force occurring in the healing period after surgery.
And Michael, do you look at white to white measurements? Someone's asked about white to white with Sulcoflex. Does it?
Not for Sulcoflex, no. For ICL, but not for Sulcoflex.
Okay. Fine. Is there anything that anyone else in the panel would like to ask, or to any other comments anyone would like to make? No, I think I'll hand over I'll thank the speakers for being involved in this panel discussion. I've personally found it very interesting and informative. I'm going to hand back to Sam Carter for Rayner just to summarize and close out the session.